Hello everyone, welcome to neurosurgical.tv. My name is Simon Downs, and we welcome you to our first case presentation, which is a challenge case presented by Slaven. We're also joined by Rakesh and Dr. Bennett. Dr. Bennett is the founder of neurosurgical.tv and internetmedicine.com, so I think it'd be right to introduce Dr. Bennett first. Welcome, Dr. Bennett.
Good afternoon, good morning, or good evening, wherever you are. Thanks a lot, Simon and Slaven. You guys are pushing the envelope.
All right, thank you very much. And Rakesh,
Thank you.
Hi, Slaven, Simon, and Dr. John Bennett. Thanks for inviting me for this presentation.
And Rakesh, can you tell us a little bit about your background?
Yeah, I'm a neurosurgery resident. I'm from India. Glad to be a part of this neurosurgical TV group.
Thank you very much. Welcome. And so now we'll go to Slaven. Please introduce yourself and tell us what's going to happen in this exciting episode.
Okay, well, hello everyone. My name is Slaven Gojkovic. I'm a medical student at the University of Zagreb in Croatia. I'm a student who is very interested in neurosurgery, and I'm a member of some neurosurgical student societies who are trying to push the borders and try to educate ourselves during our study days also. So this is a case that I wanted to present because it posed a complication to physicians who treated this young man. So I guess I should probably present you the patient. So the patient is a young man or a young boy who is only 15 years old to this date. He was born in 2002. He has a significant medical history full of different unfavorable events. So when his mother was pregnant with him, she experienced the lack of development of the neonate. So this was probably due to drugs and interactions with the fetus that she was using. So the boy was a prematurely born neonate. He was reanimated when he was born, and he spent in the incubator about 10 days. He probably had a hypoxia at this level, which was the cause of this is why he needed to be in the incubator. So he had quite slowed psychomotor development in the neonatological ambulance. So he started walking with 11 months. With 13 months in night, he had first seizure. So this patient is suffering from seizures all his life. And these seizures are quite different and strange. They're presenting in a strange way. So these seizures started when he was 13 months old, and he had 3 episodes of crying with opistotonus or stretching his body, and this lasted for about 1 hour, each one of them. After this, he hadn't have any epileptic seizures until he's 8 years old, despite from enuresis and somnambulism, and also some deficits in learning. So he had a very, very hard time trying to learn new facts. When he was 8 years old, he started to experience headaches, which continued to go on through his later years. When he was 9 years old, he had one significant epileptic seizure on a football game. He played, and so he lost consciousness and he hit the floor with his head. After that, he had some significant headaches with vomiting. They were usually followed with vomiting, and usually in the parietal region they were presenting with strong pain. Okay, so he did 2 MRIs. First one was in year 2014, and the other one was in this year. The first one was done on a significantly lower, not that strong MRI machine, but the last one was done on a 3 Tesla machine, so it allowed physicians to diagnose some changes in his brain. So what was diagnosed this year was that he had lesions in the basal ganglia. Okay, so these lesions were positioned above the frontal commissure in thalamus and apart in globus pallidum. Okay, so there was a round formation with diameter of 8 millimeters with high intensity of T2 signal and in high intensity also in flare sequence. It was iso-intensive in T1. It had no signs of restriction or diffusion. Okay, so the diagnosis that was set by radiologists, and I will show these images right away after I finish this presentation. Well, the diagnosis that was made by a radiologist was gliosis, because the cause of this gliosis was the further experienced ischemic necrosis of part of globus pallidus and thalamus. Okay, so this led to demyelinization, and there was also a differential diagnosis of hamartoma in this area. Okay, so this lesion hasn't grown in size, and it just stood there without anything else occurring. In the last 1 year, he had frequent headaches. He had episodes of walking while dreaming. He was usually screaming or looking for something on the floor. This took about 10 minutes in each attack. And when he woke from these attacks, he couldn't remember anything. In EEG, there were provoked some of the strange waves. Okay, so some ictal waves were provoked when the scanning was made, and he is now on anti-epileptic drugs, and these are trileptal and Livam. Okay, so this his seizure stopped with this therapy. So because of his deficits in learning, he contacted a psychiatrist, and the psychiatrist is the doctor who is currently leading these patients. So there was presented, the psychiatrist was the one who presented the doubt, should this patient be operated? And this is the first and foremost thing that I want to discuss with you in this case report. So I will try to screen share now and present you the images of this patient. You see this? Can you see this image here?
Yes.
Okay, so I will try to enlarge it. Okay, so this is, we will now go through a few sections here, and I'll try to present you the lesion. So here we can see the lesion in the unilateral side. Okay, so it is here in the globus pallidus. Okay, on the right side, right cerebral hemisphere. Also, this lesion looks like this. So it is 8 millimeter in diameter. Okay, so it is best seen, I think, in the globus pallidus. So I can't really tell that it's spreading into thalamus when I was looking at his MRI findings. I saw both them from 2014 and 2016, but I think this is the best image of the lesion. So I'll just enlarge it once again. Okay, so we see the lesion here. All right. I have some questions for you first after this consideration of the case. And these questions were posed by the physicians who are treating him right now. So he's currently in a psychiatric therapy because of his difficulties with learning. So the psychiatrist was worried about should this boy be operated or not, and he consulted a neurosurgeon about this. A neurosurgeon said that there was no indication for a neurosurgical approach right now, but this is very arguable. So this is the first question I would like to ask you. So is here an indication for the operative approach and for operative treatment of this lesion in neurosurgical means? My second question is, what do you think would be the differential diagnosis for this lesion? My third question, is it indicated to treat epileptic seizures by surgery in this case? And my fourth question, can we somehow connect the difficulties in learning, frequent headaches, and nocturnal occurrence in this patient with the lesion in thalamus? And do they have any partial epilepsy, partial epilepsy meaning in them? So the psychiatrist, this last question, I would like to elaborate a bit more, because the psychiatrist was worried about the part of the lesion in thalamus, because as you all know, thalamus is concerned with homeostasis of the organism, and he's binding the inner functions, homeostatic functions of the organism with the emotional part and through the limbic system. So he was worried, could this all be connected in this patient with this lesion in thalamus, and could the operation treatment of this lesion help in all of these developments? Okay, so I think this is all that I wanted to present you, and I would like now to start off the discussion with the members of the panel here. So
thank you very much. That's great, fun, wonderful, Slaven, for the presentation. Before we start, I just have some clarifications. A question: you said that the lesion is best seen in which part of the brain? Can you tell me again?
Yes, just a second. I'm sorry, I have some difficulties with. Okay, so the lesion was best seen in the basal ganglia, right from the frontal commissure. Okay, so right from the frontal commissure in basal ganglia, in thalamus, and the globus pallidus.
Globus pallidus.
Yes, this is the globus pallidum is the basal ganglia, one of the basal ganglia of the cerebrum. Okay, so this was a round formation of 8 mm with high intensity in T2 sequence and in flare sequence.
Okay.
It was isointensive in T1 without any signs of restriction or diffusion. Okay.
Thank you. And you asked, one of your questions was for the differential diagnosis, and the primary diagnosis, or the first diagnosis, clearly was what?
Yes, that was the first. Yes, was gliosis due to prior ischemic damage of this area. Okay, so demyelinization occurred, and another differential that was made was a hamartoma in this area.
And the hamartoma is not moving, it's not growing?
Yes, it's not growing, so this is questionable.
Okay, thank you very much. I'd like to open up to any more questions from Dr. Bennett or Rakesh.
Mm-hmm.
I think I'll defer. I'm having some audio, so I'll just listen today. Thank you.
Okay, thank you.
Okay, thank you, Dr. Bennett. Rakesh.
Okay, so just to sum up, I think you said that when the baby was delivered, there was a hypoxia. right?
Yes.
And then
Yes.
at 30 months he had a seizures.
Yes. They started at 13 months.
30 months he had a seizure. And the next seizure, sorry, was around 15 years, or when was it? The next seizure?
Yes. The next seizure was in age 9 years old. And he was 9 years old
Okay.
when he was playing football.
Okay. So what was the thing between 30 months and 9 years? How was the baby
Uh,
young? Was it normal?
Yes, well, I have heard only the comment that he had no epileptic seizures and he had headaches during this
Okay,
period. So
because
yes,
when it comes to the one of your questions that said should the surgery be done for this baby? So it depends on how frequent the seizures were and how much it affected his life activities.
mhm,
So it will tell us that if, should we go ahead with the medication or should we go ahead with the surgery? Because anytime surgery is has its own side effects. So
mhm,
if the boy is being not affected that much with the seizures, not that frequently, we can try with anti-epileptic medications. If
mhm.
seizures are too frequent and it's risking his daily activities, then we have to think of surgery. That's what I feel. So I just wanted
Mhm.
to know how bad was the seizures and how frequent.
Well, these seizures were quite bad because they lasted for about an hour, and they were not that frequent. I think he had very very rarely seizures.
Okay.
But when they happened, they were usually unexpected without any auras before them, and they usually occur during the night. This is very interesting in this patient. So the
Okay.
lesions were presenting with him crying, screaming, then they progressed to vomiting, and he had this was the diagnosis that was considered by the doctors who treated him was that he had partial epileptic seizures. So these were not generalized seizures, but he was not aware of after them. So he couldn't tell that he had a seizure. So this is very interesting. That is one of my questions. Is the type of seizures? How would you classify those seizures? So they occur with crying, usually nocturnal, and sometimes as an enuresis or other partial defect
And may I
during the
ask, is he
seizure.
having absent seizures too?
Well, this was kind of an absence. I think he had some absence seizures, but usually these were drop seizures. So he would drop to the floor, okay, and in some situations, so they were different in kind. And usually they presented with some uh, nausea-like symptoms, okay, and then some strange symptoms like crying, like as I said, walking while dreaming, and stuff like that. Okay, so they were very different in their presentation. If you want, I can just sum this up to. Okay, so I'll just review this again. So with 13 months, when his first seizure occurred, he had 3 episodes of crying with stretching of his body. So this seizure was not generalized, but it presented with moving of his body in a opistotonic way. Okay, so he was stretching. And this lasted about 1 hour. So he had 3 seizures like this with crying and moving of the body that lasted for 1 hour. Then no seizures until age 9. At age 9, he had one drop seizure during his football game. So he lost his consciousness and fell on the floor and hit the floor with his head. So after that, he had his first scan, as I said, and after this, strange seizures started to occur. So he started to walk during his sleeping. He started yelling during these seizures, or behaving strange. So when he had a seizure, he would look like he was trying to find something on the floor, or he was going down to the floor and moving on the floor, and this lasted about 10 minutes each. Okay, so he couldn't remember any of these events after the seizure ended. And then he started, the treatment was started, medication treatment for epilepsy, and these seizures were controlled by this. And after this, he had no experiences of seizures after this, but psychiatrist was concerned, could the surgical treatment of this lesion help if these all events about this patient were connected somehow to that formation in his thalamus. Okay, so he just wanted to ask a question: could this all of this that I described about this patient be connected with that formation, first and foremost, and then how would you describe this case? How would you describe the seizures and that lesion that I showed?
Okay.
Okay.
Thank you very much, Slaven. And what we're going to be doing is we will post the video and the questions below, and then we'll allow visitors to comment, and then at the right time you will present the answers, and we're looking forward to that. And are there any final comments from Rakesh or the Godfather, Dr. John Bennett?
Yeah, it was an interesting case, as he said, and differential diagnosis. And the questions posed are also interesting. So we'll look forward for the various answers we get. A very nice presentation, Dr.
Thank you, Rakesh.
Yeah, well, it's great, you guys. Let's push this Hangout platform and see what we can do with it. I'm sorry I had audio problems. I'll participate more in the next one, but thank you very much.
Sounds great. Thank you very much,
Slaven.
And so we'll hang this Hangout, and we look forward to doing some more. Thank you.
Thank you.
Bye.
Thanks, everyone.
Yeah.
Bye.